I'm Dr. Clare Gerada. I'm chairman of the Royal College of General Practitioners, which is a membership organisation of 42,000 GPs across the UK. I'm also a GP myself.
This is obviously a significant time of change for all GPs, with warnings of too much financial responsibility and huge governance challenges. What support and training mechanisms are required and will be provided for GPs in developing their commercial capability in the NHS?
Yes, I'm not so sure it's a matter of commercial capability. I think it's a matter of commissioning expertise and competence. And the Royal College of General Practitioners has established a centre for commissioning in order to support GPs in this process and also to provide them with education, training and a whole series of events such that right from the consulting room upwards, GPs are equipped with the skills and experience to do this. With respect to where we're coming from, we actually believe that good commissioning is about being a good GP, and it's about understanding how you use resources effectively, how you use peer support to manage patients and to refer appropriately, and how to use audits. So we think it's about layers, but starting in the consulting room and then going right up to the GP commissioning board. With respect to the question that you asked about commercial capabilities, I think what GPs will need to know is they'll need to have an in-depth knowledge on how to engage the public, how to engage third sector organisations, how to have clinical dialogues with their colleagues, how to involve public health so that public health can inform their decisions. With respect to commercial issues, I think that that's something that they will need to be taking advice on, because whilst GPs are very good at managing their practices, scaling that up to managing £80 billion worth of NHS resources, I think is something that they must gain specialist help about.
Okay. With this government's permissive policy and GP consortia to decide for themselves governance and size issues, what are the key elements that need to be considered here?
Okay, first I'm just going to deal with the size. I think size does matter. I think you have to make a decision. If you're too small, you won't be able to risk pool. And if you're too large, clearly you'll be too far away from the patient and from the GP at the ground to make effective decisions. Well, you can make effective decisions, but you lose something. Research tells us that the optimum size is around about 500,000 to get risk pooling and sufficient economies of scale. And then you can subdivide that down, but actually size does matter. And I think if you're far too small, so if, for example, some GP consortia are 15,000, well, that's little more than an average practice, and you cannot possibly commission effectively at that level and maintain the risk pool and be able to manage risk. The second issue, that's of governance. Now, governance is vitally important because, let's be clear now, GPs will be handling vast amounts of NHS resources, and the governance structure has to work and it has to be transparent. Meetings have to be, whether they're conducted in the open or not, but they certainly have to be available in terms of the decision-making processes. So the governance systems have to work. What I worry about is the time-consuming effort of 200-odd GP consortia having to work the governance out for themselves, when actually I think there is a role for central government here to streamline some of these very important issues so that GPs don't fall into traps and each consortia doesn't have to reinvent the rules. So governance is not something that has to be invented 200 times over. So governance is important, as is size, and these are details. At the moment, as you say, the government is having a permissiveness around getting consortia to decide for themselves. The college would say that there are certain things that need to be dictated and shouldn't be left up to individual consortia to decide.
With the redesign of clinical services at the heart of the solution, what, in your opinion, are the essential systems and processes that need to be put in place?
The essential systems and processes are really twofold. One is engaging your public and patients. If you do that, then things will be much smoother. So, for example, if you need to close a hospital, and it may well be that consortia have to make big and difficult decisions such as that, then you must involve the local population through whatever means, of course, that will be through. So involving the Health and Wellbeing Board, involving your local councillors, involving your local government, and involving patient groups. That's number one. With respect to service redesign, well, it's 2 words, really, or 3 words: clinician to clinician dialogue. That's 4 words. Can I do that again? So with respect to service redesign, it's 4 words: clinician to clinician dialogue. You cannot do this alone. GPs cannot redesign services in a vacuum and just do it, in a sense, top down. We're going to go to you, Mr. Consultant at a local hospital, and redesign. Now, they won't do that anyway, and I think GPs, the bit that I've heard from travelling up and down the country and speaking to people, that they most enjoy is clinician to clinician dialogue and redesigning services on the basis of what is best practice for patients.
What will the changes mean for the role of the GP in the community, working with local authorities, and the practical benefits patients will see on the ground?
Well, if this works, then what the patient will see on the ground is a much more seamless service between health and social care. So, for example, if a patient requires an aid in their home, say simplest level, a commode, but more complicated, a stair lift, well, you won't have long delays. It could well be that it's seamless, so that the person that assesses that is part of the team that's been put together to look at patients with complex conditions, and that things happen in a much easier way. There are other benefits which patients may see but may not necessarily recognise, and that's actually looking at measures, success measures, that actually means that we're improving the public's health rather than going through a tick box that their cholesterol might be lowered by 0.1 of a mil. So, for example, you might, at its best level, see better street lighting. You might see bus routes reassigned so they actually serve a local community better. You might see investment in alcohol services, because we know a fair number of patients that attend hospital that are high users of health and social care have alcohol problems. So those are the sort of things that, if this is going to work, and if it does work, you will see a transformation of services. And that's what I hope will be put in train.
Okay. Do you believe that is what will happen, or?
I think that there's going to be some areas that are already doing good things, and I think there'll be a continuation of that. I think there'll be other areas that will be hit by planning blight, in a sense. Not only are they having to go through enormous reorganisation and all that will occupy the mind, but also the cuts that are going to be made are going to actually place innovation on hold. And what we do know, that in times when resources are very, very limited, the best thing to do is innovate. The best thing is to look at something, do something completely different. And my worry is that some areas are going to be very conservative with a small c, and actually take the low-hanging fruit, put in systems and processes that actually don't improve patient care, though might save money in the short term. However, I would like to say, on an optimistic basis, my profession is probably the best at innovating. It is the best at working in hard times, and it's the best at putting the patient at the centre of everything they do. So on a scale of 0 to 10, am I optimistic? Yes, I am optimistic, but I think it's going to be hard work for the next 2 to 3 years.
Finally, what's your vision or hope for the future role of GPs in the emerging healthcare landscape, and what are the key challenges that lie ahead?
Okay, I think, first of all, I'd like to say it shouldn't just be GPs involved in redesigning services, and I do have worries, and I have to be honest about this, and I have a conflict of interest. I'm married to a psychiatrist, but I do have worries that we are actually driving a wedge between GPs and the rest of the medical profession. I do understand the reasons why GPs have been given this. We see patients across a whole spectrum of disorders. We see them social, psychological and physical. But we're not the only players in this, and it's very important that we involve all of our specialist colleagues, in particularly public health, as well as other non-medical practitioners, such as nursing practitioners. So that's number one. In terms of how I see this in the future, yeah, I mean, again, the Royal College of GPs, we promote integration, shared working, collaboration and cooperation We are concerned where competition and choice play a part, where they don't add value to patient care. We're particularly concerned about competition based on price, so lowering the price. That never, in my experience, but there's a whole host of evidence that improves quality. So I think the future is interesting. I think my profession will make this work because they'll want to make this work for patients. They'll want to make it work for the NHS. And I, through being chair of the Royal College of GPs, want to make this work for GPs.